So phrenic nerve, it is a pair of mixed peripheral nerve. Phren means diaphragm in Greek. Okay, so phrenic nerve going to supply the diaphragm. Only motor supply of the diaphragm is the phrenic nerve. Okay, and it is motor nerves for diaphragm. Root value is very important for phrenic nerve. C3, C4, C5. Okay, very commonly given in your OSPI question, phrenic nerve. Okay, in mediastinum dissection you must have seen. Next, in functional components of the nerve, there are motor fibers for entire diaphragm, sensory fibers are there, and proprioception from stretch receptors of the diaphragm. Okay, these are the functional components. This phrenic nerve carries general sensation from the pericardial, mediastinal and diaphragmatic pleura, peritoneum on the inferior surface of diaphragm, and sympathetic fibers. These are vasomotor. Okay, and how it is formed? Formation, it arises from the ventral primary rami of C3, C4 and C5 spinal nerves. Okay. What is the course? It arises in the neck, emerges along the lateral border of scalenus anterior muscle and runs anterior to the scalenus anterior. This relation is important. During neck dissection, anterior triangle dissection, you will see phrenic nerve lying over the scalenus anterior muscle. Okay, and it passes vertically downward. See here, this is scalenus anterior muscle. So phrenic nerve is lying vertically over the scalenus anterior muscle, then passes vertically downward in between the subclavian vein and the artery, vein anteriorly and artery posteriorly, and then enters the thorax and traverses superior and middle mediastinum just medial to the mediastinal pleura. Next, it passes through the diaphragm joined with the corresponding phrenic sympathetic plexus and passes through the vena cava opening, whereas left phrenic nerve pierces the left cupola of the diaphragm. Okay, so right phrenic nerve passes through the vena cava opening. Vena cava opening is on the right side, and left phrenic nerve pierces the left dome of the diaphragm. Right phrenic nerve end up in phrenic ganglion and then gives terminal branches here. Here it is piercing the diaphragm and giving branches. And in the course it is giving mediastinal branch, pleural branch, pericardial branch. Okay. So right phrenic nerve end up in phrenic ganglion and then gives terminal branches, and right phrenic nerve is shorter than the left one. See here the location in the thorax. Here is the phrenic nerve. Okay, right phrenic nerve. Here is the left phrenic nerve. So you can remember phrenic nerve lies anterior to the lung root. Okay, supplying this pericardium and this diaphragm, superior and inferior, both surfaces of the diaphragm. So what is the relations? Anteriorly lies the skin, superficial fossa, platysma, investing layer of deep cervical fossa in the neck, and sternocleidomastoid muscle, inferior belly of omohyoid and internal jugular vein. Here, anteriorly all these structures are lying. Relations in the neck, anteriorly these structures are lying, subclavian vein, brachiocephalic vein, here you can see subclavian vein, brachiocephalic vein, thoracic duct on the left side and right lymphatic duct on the right side, and posteriorly related to the scalenus anterior muscle. In the thorax, the right phrenic nerve is related medially from above downward to the right brachiocephalic vein, superior vena cava, pericardium, right atrium, inferior vena cava. See, this is the course. So, right brachiocephalic vein, superior vena cava, right atrium, right ventricle, inferior vena cava. Okay, and laterally, right mediastinal pleura. Lung and pleura will be laterally placed. And for left phrenic nerve, medial relation from above downward is left common carotid. This one is left common carotid. Then left subclavian artery, left vagus nerve, arch of aorta, here is the arch of aorta, pericardium with left ventricle, here is the left ventricle, pericardium with left ventricle. And on the left side, this is the course of the left phrenic nerve. Okay, and laterally it is related to left mediastinal pleura. Okay. Next, we are going to branches. Phrenic nerve supplies the diaphragm from its undersurface through 4 sets of branches on each side: anteromedial, anterolateral, posteromedial, posterolateral, 4 branches. And right phrenic nerve supplies the right half of diaphragm and part of right crus, and left phrenic nerve supplies left half of diaphragm, left crus, and part of the right crus, and it also supplies the pleura and the peritoneum. This is the for accessory phrenic nerve. Sometimes it is present. Here it is forming. C3, C4, C5 root continues downward, joining with the C3, C4 root more below. Okay, below the subclavian vein. Then it is called accessory phrenic nerve. Okay. So there are some clinical integration is there. Surgical identification, how you will identify. In the neck, phrenic nerve is accompanied by ascending cervical branch of inferior thyroid artery, and it may help for identification of the phrenic nerve. This point. Avulsion of phrenic nerve, this is an old surgical procedure. In avulsion, crushing or avulsion of phrenic nerve is done to paralyze half of the diaphragm and was useful in the treatment of severe lung disease. In case of lung disease, during respiration, movement of the lung will create more pain. To relieve the pain in cancer patient, you have to do avulsion of the phrenic nerve. Okay, so not much commonly done. Accessory phrenic nerve root value is C5, branch of nerve to subclavius, and may descend in front of the subclavian vein and then join the phrenic nerve in the thorax. And if present, may damage the subclavian vein during avulsion of phrenic nerve. There will be severe bleeding. Okay, because it lies in close relation with this vein, important large vein. Next is referred pain of diaphragm. Pain from the diaphragm get referred from phrenic nerve, which root value is C3 to C5, to the shoulder region through the supraclavicular nerves, which again their root value is also C3, C4. Okay. So supraclavicular nerve was 3 branches: medial, intermediate, and lateral, and they are supplying the supraclavicular and shoulder region. So in phrenic nerve compression or in some injury to phrenic nerve, referred pain you will feel near the shoulder region and supraclavicular region. So this is summarization of phrenic nerve. Root value is C3 to C5, arises from the ventral primary rami of C3 to C5. It is the course in the neck, lies along the lateral border of scalenus anterior. In the thorax, it lies just medial to mediastinal pleura through the diaphragm. And right phrenic nerve passes through the vena cava opening. Left nerve pierces the cupola of the diaphragm. And these are the branches. It gives motor branches to the diaphragm and sensory branches to the pericardium, mediastinal pleura, diaphragmatic pleura, peritoneum on the undersurface of the diaphragm. Okay. And these are the clinical aspect: avulsion of phrenic nerve, accessory phrenic nerve, referred pain to the shoulder. Next, we are going to aorta. Okay. All these are very important for your OSPI question. You have to identify the structure and related questions will be asked. Relations not very commonly asked. Relations are important for identification of structures. Okay, and related question like branches, these referred pain, clinical aspects are important for your theory and OSPI. Aorta can come as a short note, different parts of aorta, arch of aorta or ascending aorta, descending aorta, all this can come as a short note. So aorta is the largest artery of our body, receives blood from the left ventricle. It distributes oxygenated blood to all parts of the body. It is a elastic artery. Okay. What are the parts of our aorta? During the course of aorta, aorta is divided into four parts: ascending aorta, arch of aorta, descending thoracic aorta, and abdominal aorta. Descending thoracic aorta continues downward as abdominal aorta from the below the aortic opening of the diaphragm. Okay, and ascending aorta ends in the arch of aorta at the level of T4 vertebra, sternal angle level, lower border of T4, and arch of aorta arches and ends posteriorly also at the same level, T4 level. Okay, lower border of T4. Here arch of aorta have been shown and its branches have been shown. So we will discuss now the individual parts of the aorta, their relations, branch, supplying area like this. Okay. So ascending aorta ascending aorta arises from left ventricle and level of inferior border of left third costal cartilage. Okay. Length is about 5 cm, diameter is about 3 cm. So you can imagine it is a large vessel. You have seen aorta, ascending aorta during mediastinum. All the parts you have seen up to the descending thoracic aorta. Abdominal aorta you will see during abdomen dissection. Okay. So termination, it ascending aorta continues as arch of aorta at the level of superior border of right second costal cartilage. That is sternal angle level, second costal cartilage, and course it runs upward, forward, and right behind the sternum. Okay. So this part is part of the ascending aorta, then it continues as the arch of aorta. So root of ascending aorta shows 3 dilatation of vessel wall. Okay, and from here the coronary arteries are arising. Coronary arteries is supplying the heart. So these are aortic sinuses or sinuses of Valsalva. Okay, these are very frequently asked in your Viva. Dilatations are called aortic sinuses of Valsalva. 3 dilatations are present at the root of the ascending aorta: anterior aortic sinus, left posterior, and right posterior aortic sinus. Now, which sinus is arising? So, anterior aortic or right coronary sinus gives rise to right coronary artery, anterior aortic sinus. Okay. Left posterior aortic sinus or left coronary sinus gives rise to left coronary artery, also called left coronary sinus. And right posterior aortic sinus is non-coronary sinus, does not give rise to any coronary artery. That's why it is called non-coronary sinus. Okay. Next we are going to relations. It is enclosed within fibrous pericardium. Anteriorly lies the sternum, right lung and pleura in upper part, infundibulum of the right ventricle, pulmonary trunk, pericardium in the lower part. Okay. See here, this is a section through the mediastinum. You can see this is ascending aorta, here is the superior vena cava. And these are the lungs and the pleura and other structures are related. Okay. This is pulmonary trunk posteriorly. Next is posterior relations, transverse sinus of the pericardium. Here, transverse sinus of the pericardium. Next is the right pulmonary artery, right principal bronchus. Here, right pulmonary artery, right principal bronchus. To the right side, there is right atrium and superior vena cava. Superior vena cava, right atrium you will see during vertical section, and left side, left atrium and the pulmonary trunk. Pulmonary trunk is visible here. And branches are right coronary artery and left coronary artery. You see here, this is ascending aorta and here is the descending aorta. These two are connected via the arch of the aorta. Okay, and these are the sections of the bronchus, T5 level. So here is section of the 2 principal bronchus. Here is esophagus, azygous vein, 2 vagus nerve. Here are 2 phrenic nerves. Superior vena cava, pulmonary trunk is dividing into 2 pulmonary arteries. Okay, and here is thoracic duct, accessory hemiazygous vein. These are plastered with the vertebral body. Okay. So wall of the ascending aorta is not supported by fibrous pericardium. Fibrous pericardium blends at the beginning of the arch of aorta. Due to this, the ascending aorta may undergo aneurysm. That means localized dilatation of the ascending aorta. And this aneurysm may compress the trachea, esophagus, recurrent laryngeal nerve, and may lead to rupture, and that results in hemopericardium. Okay, so this is one important clinical aspect. Next is, this is the summarization. So ascending aorta begins arise from the left ventricle at the level of lower border of third costal cartilage. It continue as arch of aorta at the level superior border of right second costal cartilage, and three aortic sinuses are there: anterior or right coronary sinus, left posterior or left coronary sinus, and right posterior or non-coronary sinus. And these are the branches: right coronary artery, left coronary artery, branch from the ascending aorta. Next, we are going to arch of aorta. Okay, so arch of aorta is also a large elastic artery located in the superior mediastinum behind the manubrium sterni. Okay, here you can see the arch. This section is at the level of T4. Previous one was at the level of T5. So you were visible ascending section of ascending and descending aorta you have seen. This is a section at the level of T4. Okay, so here you can see this long section of this arch of aorta. So it is also an elastic artery located in superior mediastinum behind the manubrium sterni. Where is the origin? It is the continuation of the ascending aorta at the level of superior border of right second costal cartilage, that is at sternal angle level. Termination, it continues as descending thoracic aorta at the level of lower border of body of fourth thoracic vertebra, and beginning and termination of arch of aorta lies at the same level. Okay? That you must remember, at lower border of T4, beginning and termination of arch of aorta, and this plane is passing through the sternal angle. What is the course of arch of aorta? It runs upward, backward, and left in front of the trachea, arches over the root of the right lung, and reaches the left and posterior to the left principal bronchus. And it is convex upward and convex anteriorly and convex to the left. Okay. See here, this is the course. It is descending uh, on the left side of the vertebral body. Okay, from here it is arching upward, backward, and then to the left side. And in front of the trachea, see, this is trachea, here is the esophagus, and this is left recurrent laryngeal nerve at the tracheoesophageal groove. Here is the thoracic duct. These are the some deep cardiac plexus, left vagus, left phrenic, right vagus, right phrenic. This is superior vena cava. Azygous vein is draining into the superior vena cava. Okay, azygous vein is arching over the right lung root, and arch of aorta is forming a arch above the left lung root. This you must remember. Okay, lungs viscera is covered. Yes or no? Yes, you have seen na viscera, lung viscera. You have seen relations of the mediastinal surface. So you must have seen this. Okay, so these are the different relations of the arch of aorta. Superior to it lies the left brachiocephalic vein, brachiocephalic artery, left common carotid artery, left subclavian artery. Inferiorly lies the pulmonary trunk, left principal bronchus, ligamentum arteriosum, left recurrent laryngeal nerve, superficial cardiac plexus. Anterior and to the left lies the left lung and pleura, left phrenic nerve, left vagus nerve, cervical cardiac nerves, left superior intercostal vein, and posterior and to the right lies the trachea, esophagus, left recurrent laryngeal nerve, thoracic duct, and the vertebra. Okay. So the arch of aorta crosses the mediastinum obliquely from right to left, anterior, and all these relations we will discuss. So anterior and to the left lies the left lung and pleura, and these nerves, left phrenic nerve, left vagus nerve, lower cervical cardiac branch of left vagus, superior cardiac cervical cardiac branch of left sympathetic chain. All these are forming the cardiac plexus. Superficial and deep cardiac plexuses are there. And left superior intercostal vein, these are lies between the left phrenic and left vagus nerve. Next, posterior and to the right lies the trachea, esophagus, left recurrent laryngeal nerve, thoracic duct, and vertebra, fourth thoracic vertebra. And superiorly lies the structures, left brachiocephalic vein, branch of arch of aorta, three branches, brachiocephalic trunk, left common carotid, left subclavian. Brachiocephalic trunk, left common carotid. Posterior and to the right, superiorly lies this left and thyroidea artery if it is present. This is going to supply the isthmus of the thyroid gland, direct branch from the arch of aorta. And inferiorly lies bifurcation of pulmonary trunk, left principal bronchus, ligamentum arteriosum, superficial cardiac plexus, left recurrent laryngeal nerve. These are the branches of arch of aorta, breath from right to left. Brachiocephalic trunk, also known as innominate artery, okay, and left common carotid artery, left subclavian artery, and this is occasional branch, thyroidea artery, supplying the isthmus of thyroid gland. So this is summarization of arch of aorta. It begins as continuation of ascending aorta at the level of superior border of right second costal cartilage. Terminates, continues as descending aorta at the lower border of T4 vertebra. Branches are these four branch, brachiocephalic trunk, left common carotid, left subclavian, occasional branches, thyroidea artery, okay. And these are important clinical aspects. Aortic knuckle on the radiograph you will see in some patients. Coarctation of aorta, patent ductus arteriosus and aortic arch, aneurysm. We will discuss these in details. So arch of aorta begins and terminates at the same level at the plane passing through the sternal angle anteriorly and lower border of T4 vertebra posteriorly. And the brachiocephalic trunk, which is also known as innominate artery, innominate means no name in Latin. It divides into right common carotid and right subclavian arteries. Next, this is aortic knuckle or aortic knob. This you will see during chest radiograph, chest X-ray. Okay, chest radiograph's PA view, arch of aorta produces a small bulb-like projection. This is normal X-ray you will say. Bulb-like projection at the upper end of left margin of cardiac shadow. This is left margin of cardiac shadow. This is right margin of cardiac shadow. So upper part of the left margin of cardiac shadow you will see aortic knuckle. This is formed by arch of aorta. Okay, called aortic knuckle or aortic knob. Next, coarctation of aorta. Coarctation is congenital narrowing of arch of aorta. It reduces the lumen of aorta and causes obstruction to the blood flow. Okay. Coarctation may be preductal coarctation proximal to the ligamentum arteriosum. Here, this is ligamentum arteriosum formed by obliteration of this patent ductus arteriosus, which was present in the fetus. So, it may be preductal proximal to the joining of ligamentum arteriosum or postductal distal to the joining of the patent ligamentum arteriosum. Okay. So maybe preductal coarctation proximal to ligamentum arteriosum and postductal coarctation distal to the ligamentum arteriosum. And these cases there will collateral circulations will develop because in the distal part of the lower limb and abdomen it will not getting blood supply. So to maintain the blood supply, collateral circulation will develop, mainly between the posterior intercostal arteries, which are branches of descending thoracic aorta, and the anterior intercostal arteries, which are branches of internal thoracic artery, subclavian arteries. And enlarged posterior intercostal arteries will produce notching of the lower border of the ribs. Rib notching you will see during X-ray. Okay. Aortic knuckle have been shown here. Today in dissection class there is chest X-ray. We'll discuss chest X-ray. You must see this aortic knuckle frequently given in your OSPI. Okay. Next we are going to patent ductus arteriosus here. The ductus arteriosus have not obliterated to form the ligamentum arteriosum. In fetal life, blood from the right pulmonary artery, see this is pulmonary trunk, it is divided into right and left pulmonary arteries. So blood from the right pulmonary artery passes to the aorta through the ductus arteriosus, patent ductus arteriosus, and it closes or obliterates within week after birth. Anatomical closure occurs at the level of 4 to 12 weeks, and this obliterated ductus arteriosus form this ligamentum arteriosum. Okay, and these are important short notes: coarctation of aorta, patent ductus arteriosus. You have short note in anatomy, also in medicine, surgery. These are very important. Okay, in embryology, if does not close after birth, it leads to patent or open ductus arteriosus, and that may require surgical closure. Okay. In pediatrics also these are given. Next is aortic arch aneurysm. Aortic arch aneurysm is localized dilatation of the aorta. Aneurysm means dilatation. May result into mediastinal syndrome due to compression of the adjacent structures. Superior vena cava, pulmonary trunk, all this can be compressed, and different nerves. So here is the preductal coarctation. This is postductal coarctation of aorta. Okay, and here patent ductus arteriosus have been shown. Next, we are going to descending thoracic aorta. So we have completed arch of aorta and its clinical aspects. Arch of aorta very frequently given short note, prepare as a short note, and its clinical aspect you prepare as a short note: coarctation of aorta and patent ductus arteriosus. To descending thoracic aorta, it is continuation of arch of aorta at the level of lower border of T4 vertebra, lies in the posterior mediastinum. How it terminates, it continues as the abdominal aorta by passing through the aortic opening of diaphragm at the level of lower border of T12 vertebra. These are the relations. Anteriorly lies the root of left lung, pericardium with heart, esophagus, diaphragm. Posteriorly lies the vertebral column, hemiazygous vein, accessory hemiazygous vein. To the right, esophagus in the upper part, azygous vein, thoracic duct, right lung and pleura. To the left, left lung and pleura. These are the branches, 9 pairs of posterior intercostal arteries for 3rd to 11th intercostal spaces. Subcostal artery, 1 on each side, and 2 left bronchial arteries, esophageal, pericardial, mediastinal branches, superior phrenic arteries for diaphragm. You know these names. These names will be asked in your OSPI. If it is, you have to identify. Okay. So descending thoracic artery, you prepare the branches. Next is pulmonary trunk. Origin arises from the infundibulum of the right ventricle, level of sternal end of the left third costal cartilage, terminates by dividing into right and left pulmonary arteries at just inferior to the concavity of arch of aorta, level of sternal angle. Length is 5 semi. Branches are these two: right pulmonary artery, left pulmonary artery, and both are carrying deoxygenated blood to the corresponding lung, right and left lung. These are clinical aspects. Sudden occlusion of pulmonary trunk, thrombus from the right ventricle or large veins may cause sudden occlusion of the pulmonary trunk. Pulmonary artery catheterization is done in right heart catheterization. It involves insertion of the catheter into the pulmonary artery through the internal jugular vein or subclavian vein. So catheter will enter through superior vena cava to right atrium, to right ventricle, then into the pulmonary trunk. This is the route, and it is useful for assessment of respiratory distress, assessment of right-sided cardiac functions, and so on. Okay, that's all. So clear up till this? Any queries? So prepare different parts of the aorta as a short note. Must prepare arch of aorta. Okay, arch of aorta and coronary sinuses are asked in your Viva. And phrenic nerve also important for your OSPI. Sometimes come as a short note. Okay. So different parts you must know. You will be asked in your different vivas, bones viva, viscera viva. You will be asked different parts. Ascending aorta, arch of aorta, descending thoracic aorta, abdominal aorta. Okay. Okay. Any queries? And prepare the clinical aspects. Those two for short note. Coarctation of aorta, patent ductus arteriosus.